I'm going to ask our experts to join me now. Joining me will be Dr. Tapp, who is a Chief of Sarcoma Medical Oncology Service at Memorial Sloan Kettering Cancer Center. Dr. Ravi, who is a medical oncologist in the Department of Sarcoma at MD Anderson Cancer Center. Dr. Vesel, who is Chief of Division of Palliative Care at Tufts Medical Center, and who many of you may have interacted with, and is an expert in pain and non-pain symptom management. And Dr. Gupta, who is cross-appointed as a staff oncologist at both the Hospital for Sick Children and Princess Margaret Cancer Center in Toronto, Canada. All right, welcome all. I think what I'm going to do is kind of just throw out the questions that have come in. I've tried to group them into themes, and then anyone on the panel, feel free to jump in if you have feel that you have something to contribute to the topic. So the first kind of big theme that has come in is, a lot of EHE patients get this diagnosis. It's a new diagnosis, and they have a lot of immediate questions. And one of the first immediate questions is, how do I know my diagnosis is correct? And so if anyone has any thoughts for sort of advice for newly diagnosed or potentially diagnosed patients, particularly if they perhaps are seeing a clinician or working at a center that does not have experience with EHE, the community had quite a few questions in that area. And feel free to just jump right in.
David, I'll start. I mean, I think it's so important to get connected to medical centers that have expertise in EHE, and that's really important not only to have pathology reviewed by an expert musculoskeletal pathologist to make sure the diagnosis fits, the molecular genetics fit, and also the clinician to make sure that the clinical sequelae of the disease are really in line with what we expect with EHE. I also think getting in touch with patient advocacy and support groups are a wonderful way to really direct people to the right clinics, and that's really important.
Any other thoughts from the group?
No, I totally agree with Bill. I think the expert pathology consultation clearly is one of those things that can't stress the importance of it in a high volume center. It's really helpful, especially if it's in a more community setting that this is picked up because of the rarity of the illness. So totally agree with connecting with, and the foundation's been playing a phenomenal role there as well. So I'm hoping that will continue to persist globally.
And I will note that on the foundation website, as well as on the Facebook group and other areas, people can get access to where they can go to get this level of expertise.
May I just answer this question in a different way?
Please.
Just, watching patients' behavior, I think many patients are afraid to go for a second or third opinion. And in fact, you will find out that the physicians who perhaps are not comfortable or want to learn about the rare disease will readily help you to get a second opinion. And it doesn't mean that they will get somehow hurt or their feelings will be hurt. So I just encourage patients to look at the second opinion as just simply learning what is the best way and which place is the best place to be treated.
Thank you so much. And so another theme that kind of has come in with these questions is, patients wanting to feel empowered to do as much as they can to help themselves or loved ones if the loved ones have been diagnosed. And there will be this timeline for clinical interventions. It may be watching and monitoring. It may be treatments. But in terms of what the patient can do sort of early on in the diagnosis, on their own, things related to diet or lifestyle. Do you have any thoughts about things patients can do to sort of maximize their own benefit and take an active role in their care while this timeline is working through? Because sometimes this is slow and frustrating, right? And people want to do as much as they can early on. So I'd love feedback on that topic. We got quite a few questions in that area.
Maybe I can start with this one. I think one of the hardest things in living with EHE is exactly that, is living with the disease. And so it's, as soon as anyone receives the diagnosis, it's like the clock has started with that entity, and it's almost that it's now a lifelong kind of part of one's identity. And so my advice to anybody would be, don't change the way you live, actually, and rather to still continue to do all the things that you've been doing till date, while in parallel, all of the workup and consultations, et cetera, are being undertaken. Because if you put the rest of your life on hold during that whole process, it will make time seem very, very slow. But hopefully, especially if it was an incidental finding, or if you do have quiet asymptomatic disease, then as that medical process continues, you can still continue to work, take care of your family, et cetera.
Thoughts from other members of the group?
I totally agree with that. And I mean, the other thing I think I'll add to this is it's very important to understand how the disease is affecting you. And so being a little introspective, especially in the beginning, when you know you have a diagnosis, to understand the symptoms that you may have, because that's very important for us as clinicians to often determine the types of treatments, if treatment is necessary, or what the goals of care are. So we have to spend a lot of time with our patients to get to know them and how the disease is affecting them, to understand the appropriate care. So oftentimes in between visits, taking note of that is very important.
Yeah, I would also, that's I would add to that and say that the true North Star to really follow is your symptoms, because it's so crucial in our decision making to initiate therapy. Is even therapy required? And Abha's point about trying to make sure that you don't leave life behind is so critical, because you can sometimes run into decades of I have a good story of a patient of mine who decided don't need a new pair of sneakers because this is no longer a pressing need, and the reality is that's so not true. So I think being cognizant of the symptoms and not let the internet content or a research article and then going to your calendar mark off dates is not the approach. Every patient, as Dr. Wagner was indicating, it's a very varied clinical course, and because of that reason, to understand that variability and that heterogeneity is inherent in this particular area and how you feel. And that's one thing we all notice, is that performance status directly correlates with how well you're going to do. So if you are actually feeling well, that is the biggest piece of news, that to engage back into life, and then make sure that your provider is well synced up with the symptoms. So that's such a critical thing.
I would like to add to Dr. Gupta's comment, as well as that, it is learning how to live with the disease, and to live is important. Over the last year, doing the seminar with all of you and others who perhaps are not here today, there is that feeling of isolation. It's a very rare disease, and many patients feel isolated, even in the doctor's office, even in the cancer center. They feel very lonely. So looking for the community, finding trusted friend, trusted people, and sharing the experience gets you out of that isolation and gets you back to living with it, than being totally isolated and feeling despondent for perhaps a reason that you shouldn't feel despondent at the time. So I just encourage you to find the trusted community.
Dr. Vesel, kind of a follow-up on patients sort of managing their own lives outside of the clinical care. One of the common symptoms we hear about is pain, and sometimes quite severe pain. And, and it can show up in ways that have been surprising to some patients. So for example, they may be on a treatment regimen that's actually being successful, right? So they might be stable or even seeing sort of tumor shrinking, yet the pain is staying or increasing. Did you have thoughts about managing that, especially for patients who may be living with this disease for decades, that's certainly an important quality of life issue.
Sure. We don't have enough time to explore all. I have a lot to say, but what I would like to convey is please don't take no from clinicians who are treating your pain. Explore more. There are many modalities for pain syndrome, and partnering with clinicians who you trust and who understand your pain, or looking for ones who will not just, push you away. This is in your head. This is in your brain. This is not, or, this is not your disease. It shouldn't cause as much pain as you are telling me it's causing. So move on, find a team of clinicians who you trust, who trust you, because your pain is your authentic experience, and explore pharmacological and non-pharmacological intervention. Don't be shy to try something that perhaps a colleague told you, or a friend told you. Check with a physician, look for the interactions with medications and the side effects, but explore. And I think that that's really important, that you don't give up on your pain management. We do see patients who have very severe disease, and we are using perhaps FDA unapproved medications for that particular rare disease symptom. But we are proudly partnering with patients who have very severe symptoms. We don't want to, patients to be in pain that will limit their life. So I'm just encouraging to explore. There are many proud oncologists, palliative care, pain clinicians, and primary care physicians as well, who want to partner with you.
Thank you. Thank you so much. So one of the questions we get on sort of managing lifestyle diet are people are always looking for things that might benefit. But let me flip the question. One of the questions that came in is kind of asking if there's any no-nos specifically tied to EHE. They might be general no-nos for healthcare, but are there any specific no-nos for EHE, like smoking, drinking, eating meat, other things like that, that would be a specific concern for EHE?
I think, as with all sarcomas, what I tell my patients is sarcoma is a disease from within. It is a disease of connective tissues. It is not an environmentally influenced disease, in contrast to most of the other common adult cancers, such as lung cancer, skin cancer, colon cancer. So in fact, there's really no external modifiable issues or elements, in fact, that in my mind, we can do to externally control the disease. However, I think, as Tamara has already said, what is more important is how is one able to control one's symptoms associated with the disease? And that is what we do have control over.
Yeah, I saw everyone else shaking their head no as well on the no specific no-nos. So not to encourage continued drinking and smoking for other health reasons, but if those are part of your quality of life, it sounds like there's no reason you need to stop.
Can I actually add, I don't know, I'm interested to hear of what my colleagues say as well. One of the common questions that we are asked is, should I avoid sugar? And, I personally love dessert. And I think that when people are already faced with a very stressful situation, such as a diagnosis of EHE, I think it's actually really important to identify the top 5 things that give you pleasure. And if dessert is one of them, great, don't delete it off the list. But I want to ensure that my colleagues actually also say, concur with this idea that it's, in contrast to other adult cancers, this idea of avoiding sugar is not relevant in EHE and other sarcoma.
Thoughts on that from the rest of the group?
I agree with Dr. Gupta as well. I think that being everything in moderation, not to go to the extremes, and what gives you pleasure likely will be balanced with less side effects and more pleasure. So I absolutely agree, moderation and not extremes in diet, or if the diet makes you miserable, then don't do it. It's not worth it.
Excellent. So we saw this question come up on the Facebook page, but it also came up as part of the Q&A for this session. It's a bit more specific, but it's a really important life choice for some patients, younger women in particular. considering pregnancy after a diagnosis. Do you have any thoughts on the ability to have children after an EHE diagnosis?
Yeah, it's tough, but I think, we think of the different types of EHE, but I've had plenty of patients, especially with, the type of disease where we see tumors in the liver and small tumors in the lung, which we often see in a younger patient population. And I've had multiple women, have multiple pregnancies during EHE, and it can be monitored and watched closely. Personally, I haven't had experience where we've seen flares. I've had a few patients come in though, who possibly had a flare after a pregnancy. So it's a little bit hard to say, but I think it can be done very safely in that situation.
Yeah, I would agree. The key thing to kind of remember is that in many of these vascular tumors where the immune system kind of plays a very important role in keeping the disease under check. In EHE, it's not so very clear, that mild immunosuppression that comes along with pregnancy, whether does it really have a true impact on the disease itself is not entirely certain. Of course, in the localized epithelioid hemangioendothelioma occurring in the extremity that has been curatively managed, there should be absolutely no reservations. In patients with small volume disease that really has not really moved much over a prolonged period of time, that really there isn't any restrictions there. The only areas where, if it is a planned pregnancy that is being thought about in someone who's got a lot of peritoneal disease or where there's lack of stability. So there's a lot of individualization that needs to happen. So I certainly, as Dr. Tap indicated, discuss it with the primary treatment team. Always, this disease spans several years in many patients who don't have any kind of pleural or peritoneal involvement. So it's always a good idea to bring that up. Hey, I'm thinking about this, and what would be the required stage in which you would recommend trying to pursue it. But I don't think there's any data. I agree completely with Dr. Tap as well. I don't know, Abha and Tamara, if you have any comments on that.
No, I completely agree with everything both of you have said. I mean, I encourage all my patients, again, just to continue their family planning as they would have even in the absence of the diagnosis. It's a very personal decision. So in fact, if a physician tells you not to have a baby because you have a diagnosis of EHE, that should actually raise eyebrows. I don't think that's appropriate at all.
Well, and since you mentioned immune system, we had a number of questions that kind of centered around the confusion and the complexity, probably is the better phrase, with the immune system and EHE. And this is going to be a hard question to answer, but love your thoughts on this. There seem to be some paradoxes with the immune system with EHE, especially that, there's been some reports of immunotherapies being successful. There was, at least from the, some of the early analysis of the cancer, it seemed to be the type of tumor that would be considered a cold tumor and perhaps not responsive. There's questions about, do we want a robust immune system? What happens if we don't have a robust immune system? For example, those who get organ transplants and have their immune system suppressed. There just seems to be a lot of paradoxes about the immune system with EHE. And this is kind of a general question that subsumes a bunch of questions that came in. But what are your thoughts on that paradox of the immune system and EHE?
So this one, the answer is highly complex because it seems to, like I mentioned earlier, initially when we started engaging with checkpoint inhibitors, it seemed like a really good strategy to incorporate them as monotherapy in patients. If you have a slow-growing cancer where the immune system is somewhat interfacing, would it really help to utilize these sort of agents? From a hypothesis standpoint, seemed like a really good idea, but we've had some situations where patients who have gone on monotherapy have had a bit of unexpectedly rapid progression kind of situations that have evolved. There's literature reports of at least 3 or 4 specific cases where in combination some have had good outcomes, lasting stability, which is also hard to evaluate in EHE because a lot of patients can have it depends on how you select the patient. Some patients can do without therapy for a while. Such a patient going on, checkpoint inhibitors or a strategy in that direction doesn't really help. And to add to the complexity, you've got agents that are immunosuppressive that tend to do really well. In addition to the sirolimus example, we use a lot of oral Cytoxan, which is alternated with steroid, which is a whole week of prednisolone that is going in, and patients feel fantastic. There is no disease doesn't take off like crazy. So the quick answer is I have no idea what would be safe and what wouldn't be. And I do think that with steroids, I have not seen a very rapid takeoff of the disease in any particular case. I think both the sirolimus approach and for steroids are relatively safe to use based on our experience. But really, to truly answer this, we need a controlled experiment where there is some uniformity in the kind of patients that we select and then randomly assign them to really answer that question in its detail. And at the molecular level, I don't envy Dr. Rubin's job at all, because it's a very complex one to unravel, I think. But I would love to hear what Bill and Abha have to say about this.
Yeah, I would agree with Dr. Ravi. I mean, and I like the way you talked about the paradox to it, because it's definitely not straightforward. It's a different disease in different people, right? And I suspect we're also seeing that when it comes to the immune system. It's also a disease that, as you mentioned, is very cold, but we talk about it clinically as being inflamed, and inflammation is an important part of the symptoms. And when we talk about symptom management, how can we also use anti-inflammatories to help people? And we also talk about it as this infiltrative disease, right? But anytime that you have diseases that can be indolent for long periods of time, you also wonder if the immune system is playing a role to keep it that way. So I agree. It's something that we're very interested in, that we need to think about how to do correctly from a patient standpoint. I think if you're thinking about immunotherapies versus immunosuppression, these are the conversations you need to have with your clinician. And I do think when we think about checkpoint inhibitors and immunotherapies, we really do have to think about combinations in controlled clinical trials, like was mentioned. So it's very complex. And even to us, we struggle to figure out the right application of some of these drugs in the right patient.
Any other thoughts on the paradox before we shift?
One additional thing I would just add in there is that because, if you look at the literature, you'll see there's one case report of a patient who went on this agent plus the other agent, and then there is another case report. I was sort of wondering if the foundation itself can play a role in keeping a little bit of a registry of who is on particular drug classes, so that there is an opportunity to actually collect some outcomes specifically. And it looks like you guys are already down that particular path. But patients on clinical trials across the country and across the globe in varying different agents that belong to the same drug class, and the ability to kind of collapse them all together at the foundation level, kind of the work that Dr. Stacchiati kind of kicked off, is going to be quite powerful, and engaging with academia in a way where that can actually be properly be leveraged and reported in aggregate can actually be very hypothesis generating, and may provide some useful insights, and publications like to the caliber of the mTOR publication that came out of the Italian Rare Cancer Network group as well. So that would be really something that the foundation itself can support. Who's on what trial, and how do we really merge those outcomes in a meaningful manner for a summarized view of what might be happening.
Yeah, and we're definitely actively working on that. And I'll just make a pitch, so that since we've got a lot of patients listening today, that the ability for that type of analysis to be helpful and to get the returns and figure out how to treat this disease better is going to be highly dependent on patients participating in those projects. So I would encourage people to check out the EHE Foundation website and to get as actively involved as possible, because everyone's going to be able to help each other here. That actually shifts us perfectly into the next big theme that I saw with these questions, which is treatment decisions. and weighing the many, many different options, right? And so the question we get over and over and over again for this presentation and others is this hard decision between when to actually do active therapy versus watching and waiting. And the theme I think we've been hearing is it's kind of patient specific, but we've definitely seen some patients sort of concerned about whether they're getting good advice from their clinician on this. Is there anything you can say specifically about the things that should be weighed in making a decision in transitioning from watching and waiting to treatment, and anything specific about patients who have those concerns on whether they're getting good advice?
I don't know. This is
Yeah,
Bill, you want to go first?
Yeah, I think it's, again, very individualized. I mean, I think all of us, I don't want to speak for everyone, but definitely when I see a patient with EHE, you kind of have an idea of what the disease is trying to do to them, and an understanding of the different subsets of the disease and how it presents, as well as some of the molecular findings of the disease. And I think there's definitely a subset of patients that do well without any treatment. And we've all had patients for years and years and years where we followed and not needed to intervene, or occasionally, they may need a procedure on one tumor that's behaving a little differently. I think when I see patients in that category, part of it is spending the time and talking to them about the importance of watchful waiting, because I often get concerned when I see people with a new diagnosis that go to extremes, and they end up affecting the course of their life, the quality of their life, by doing too much, right? And I think that's always a worry. To what extremes do you go when you may have a disease that's going to behave very indolent, and how to understand the disease? And then I think we have a different subgroup of patients that have very aggressive disease from the start, and I do think understanding how it affects the patient, the symptoms that they have, all plays in a role in how we need to initiate treatment, when we need to initiate treatment, and actually what do we watch to understand the efficacy of the treatment. This is not a disease where we can follow other rules and paradigms that we use, so we have to think very much about how our treatments may be helping patients, right? So I think understanding which category people initially fit in, and then identifying the treatment, becomes very important. And again, when I speak of this is patients who usually present with multifocal or disease in multiple spots, as opposed to localized disease where they may be just involved with surgical resection.
Other thoughts?
Abha, go ahead.
So I think that in medicine, we always think about time as a really important factor. So I agree completely with what Dr. Tapa said. And, at one time point, we have no idea what the pace of disease is. Sometimes even 2 time points doesn't give you the curve. So very often, especially if somebody has no symptoms and we're treating a picture, I do rely on what is that rate? What is that change over time of the scan? Because we always sometimes think that we're doing something great by offering treatment, but maybe we're not, because actually the pace of the disease is like this. And if you remember the curves that were shown in the last presentation, after that initial drop of people who unfortunately do have aggressive disease and might pass away from their disease in the first 2 years, after that, that curve was flat, meaning that that's the proportion of patients who probably have indolent disease. And I actually find the frequency of follow-up to be just as challenging as making the decision about when to initiate treatment. So for example, should I do a scan every 4 months or every 6 months when I know that the disease has been so indolent? And so similarly, when trying to make a decision about, do I initiate treatment, I often say to individuals, look at your body and see how you feel. If I was riding the subway with you today, does it feel like you have cancer? Is there anything about your body that says I have cancer? Does anything hurt? If nothing hurts, And all we're doing is we're treating a CT scan because something has grown by 1 millimeter. It doesn't feel good. Doesn't, whenever the oaths we take is do no harm. I don't feel like doing something if a CT scan over 6 months says that something's grown over 1 millimeter. So I guess my philosophy in initiating treatment is not to look at the scan as much as looking at the scan, but over time, not one time point. And number two, and more importantly, thinking about one's symptoms in one's body.
Yeah, I think that's so important. The use of symptoms as a guide and making sure symptoms are appropriately managed. I'm sure Dr. Vesel has some to add here. Is going to be a very, very critical step. I mean, one key thing I always tell patients is the goal of therapy has to be established up front. So if you are symptomatic and you're trying to treat and your symptoms are worse, you're not hitting the goal. At that point, you kind of have to back off fairly quickly. If you are initiating therapy because of actual volumetric growth in the tumor, that is a reasonable goal to have, but you can't go from had a 3 millimeter growth over a 6-month period, as Dr. Gupta was indicating, and then start therapy, do another scan in 6 weeks, and it's stable, and therefore it is working. So you have to look at the change and normalize it by time, by unit time, to be really produce an impact in the rate of growth. Now, shifting to the other end of the spectrum, patients who have involvement of the peritoneum and pleura are clearly a group that has very short survival. All of us have sort of kind of agreed that that patient population needs some form of intervention because they generally tend to they nutritionally start depleting, they lose weight dramatically. These are all danger signs: presence of pleural effusion, presence of ascites and peritoneal involvement, rapid loss of weight. These sort of things are time points where you really want to, and that too, to do it in the logical fashion Dr. Gupta was indicating, really mark out, okay, this is where I am, this is the rate of weight loss, or this is the rate of growth, and with therapy, are we really trying to impact that and being able to switch out therapies as needed in order to help in that setting? So those are two things that I would remember. I totally agree with what Dr. Tapp and Dr. Gupta was talking about. I'll hand off to Dr. Vesel for the symptom-related management.
Thank you. I love the idea of working together with oncologists because it's not only a decision about cancer-directed treatment, but it's actually supporting patients to run this marathon. This is not a sprint, right? And learning how to actually run this marathon, long distance running, or whatever your analogy is, it's this ability to become resilient and go with the punches, right? To be less reactive to, as Dr. Gupta and the rest of the oncology team were sharing, not to react on every millimeter of change. The same is not to react when you are being told that, and kind of getting to know your body, getting to know what the signals are so you can present the physicians when the symptoms come. And that takes time to learn your own body. We are not usually living in our body. We are usually living in our brain, right? So this is an opportunity to actually learn about yourself, and then starting to really be able to add to the CT scan or bone scan or whatever the physician is following your subjective symptoms, and that become then this dual pathway to make the decision about the treatment. Otherwise, you may become worried about a pain in your toe, and pain or toe becomes so misleading, then your physician doesn't know what to do with that. So working on yourself, and that doesn't mean that it's working in solitude. Work with your whole family, work with your friends, learn together how to improve your mental health and physical health together with your community. That will help you to live better.
And David, I just want to me, bringing back that word, the paradox, because I think, it's important for patients, what I'm hearing here is interesting, right? Because what we're saying is when we have indolent disease, we often end up focusing more on the size of the tumor and millimeter changes in the tumor, right? And that's what becomes the focus. And as you heard, a scan to scan is never stable, right? Because a human being is trying to measure millimeters and differences, right? So it takes time to understand if things are growing or not. Just as if we start a therapy, it's going to take a lot of time to know if we're helping. But when you think about the more aggressive cases, it's often not the size of a tumor we're following, but the symptoms, right? So as Dr. Ravi and everyone said, we're really trying to understand, are treatments effective by, are you gaining weight? Are you in less pain? Are you, so it's that paradox again of what we're treating and why, as opposed to what we standardly do in cancers.
And I've got one last sort of specific question before a wrap-up question, because we're getting near the end of the time here. The last sort of question on this theme is for those who have some indication of a more aggressive cancer where they're going to need some active therapy. EHE, is going to be different than a lung cancer or a melanoma, right? Because we don't have hundreds of thousands or millions of data points out there that say this likely works for your category. And we have a lot of experimental things out there, and on the Facebook group and elsewhere, people are seeing what other people are doing. Any thoughts or patient advice for how they help navigate this themselves and the questions they ask to their clinicians and their teams figure out, do I do a transplant? Do I do an ablation? If I do an ablation, do I do, ultrasound, or do I do cryo, or do I do, heat? Do I enter one of these clinical trials with a potential TEAD inhibitor as these come online? What's your thoughts in terms of how patients should be having these communications, since we don't have and will never have great statistical data with EHE? Sorry, tough one to throw out there.
Yeah, that's a bit of a tough one, David, because it really involves quite a bit of detail regarding, I still recall a patient of mine that we ran into and started early intervention in a left lobe of the liver EHE using with beads that had some radiation payload in it, and started to develop substantial toxicity in the GI tract from scatter from it. And the treatment was worse than the disease itself. It was asymptomatic disease that we clearly pushed over into a complete a difficult situation in a very motivated, committed patient. I'd actually say that it's very complex because of the location of the tumor, the rate of change, what kind of symptoms are going on, what kind of therapy options are available. The joke is I have a TEAD inhibitor trial open, but there are 2 patients have already been enrolled, and they're both not my patients. I still struggle to find the right patient to kind of put on that sort of a study, and part of the reason is really that it really has to mesh well with what is going on with the patient, and it's a complex decision-making process, and it has to be in the right kind of individuals. The problem with some of these trials is that you can withdraw at any time, but the trial is really designed with kind of tripwires in a way that is probably not fully attuned to EHE, especially in the phase 1 or early stage setting. And you could go like 9 months with an ineffective agent, getting side effects on a trial that's not even working because your disease is growing at such a slow rate. It doesn't trip the wire for a very long time. So all of that has to be kind of kept in mind as you're picking therapy. So I'm not really sure. The only suggestion would be to and we have a lot of high volume sarcoma providers across the nation. I mean, saw some superstars here earlier today, and there's more out there. So I don't think any territory is too far away from, these high volume centers that can certainly provide a great deal of insight in that particular decision making. I'd strongly encourage like trying to do that with folks with experience. Whenever you get the cancer diagnosis, there's always this whole spider on my back, get it off kind of a mentality. but you really have to be very cautious about this because the act of trying to control it can also produce quite a bit of damage. So complicated question, and it really requires some expert input in order to sort that out.
All right, with the last couple minutes here, I'm just going to have everyone go around in the circle here, and you might not have the same arrangement, so I'll call out names. And if you just have a sort of a last parting thought on what you think patients should know that we haven't talked about, or sort of your view of the hopefulness of the future, because so much progress has been made on the EHE front compared to where we were a decade ago. Just a parting thought from each of you for the patients listening today. Dr. Tapp, you're in the corner of my Brady Bunch group, so I'll go around in that direction.
I'll start with the hopeful aspect. I mean, what I'm really hopeful about is how the community is really organizing around this disease. And this is internationally, and there's some huge efforts in Europe. There's some huge efforts in the United States, and they're coalescing, right? And what that comes down to me is understanding the biology, understanding how to find new treatments for this. I think there's large efforts to understand the natural history of the disease, the different variations in it, best responses to the therapies that are given out in the community, as Dr. Ravi said, and then how do we bring those together and make these data sets available internationally, right? And so I think this is what I'm really excited about. To me, it's a little paradigm shift in how we look at ultra rare cancers. I think EHE, because of the involvement of the patients, because of the involvement of the patient advocacy groups, is really going to be one of the diseases where we help figure this out. And so that's what I'm really excited about.
Dr. Ravi?
Yeah, I completely agree with Bill. I cannot understate the importance of organized. Is my treatment experience captured in a digital format, in an analyzable format for the community that is working on this problem is something every patient should ask. And where is that data, and is that data being put to good use? I think in these two components where patients also hold the foundation accountable, hold each of us accountable. I gave you my treatment data. That real world data and its analysis is so valuable in a rare disease getting organized, as Dr. Tapp indicated. Probably there's nothing as important as that in making advances, not only just in the treatment aspect of it, about symptoms, how we manage them, about patient-reported outcomes. There's so much more that we can do in order to inform people about, if I get diagnosed tomorrow, I need to know that, 60 to 70% of patients retain their same employment a year down. And that's an important thing for me to know, wondering, what am I going to do for college for my kids? And, so no aspect, every aspect of the data collection process, especially from the treatment experience, the disease experience, and also outcomes of the novel agents that we are looking at, we need to strive to collect and aggregate it and make sure that the new generation coming on is analyzing and publishing and getting this out there into the public realm, so clinicians can then be able to search that out and be applying it to care of the patient. So that would be such a cool thing to do.
Dr. Vesel?
Hard to say the parting words. I am struck by even just the title of this conference, Empowering Patients, and I think that that's where my thought is. The power is for patients to be active participants in their illness, and I think that you gain more when you learn cognitively what's going on with your disease. And it's hard in the beginning because not all of us were sitting at a medical school, right? So it seems like a foreign language, but I think gaining the cognitive understanding what's going on, partnering with researchers, as I see here, and clinicians and everybody else is the answer to live with this illness. And making sometimes tough decisions requires every patient to get to know themselves, right? And I think that that's a big piece. That's a lot of work to get to know yourself and how you behave and how you make decisions and how you undergo treatment and suffering or pain is can be actually leading to empowerment of living with this disease. So this conference and conferences that EHE is doing are absolutely remarkable. I'm a pediatrician as well, and I see a lot of communities with a rare disease in pediatrics. This is absolutely remarkable to go globally with this rare illness. So what a privilege to be part of this community for me.
Well, thank you for being part of it. Dr. Gupta, final words.
Thank you so much. And I definitely echo everything that my colleagues have said. And it's actually really nice, even for us as the medical community, to have such a tight-knit sarcoma community. Actually, we, it really, I think, just as the EHE patient community is so close-knit and tight, so I can assure you that so is the medical community. I think that, to me, the thing that we've also are learning as well is this idea of living with chronic cancer. And I can't emphasize the emotional burden of that enough, and how, every day people are living with this fear of cancer recurrence or fear of cancer progression. And I just, again, put a plug out there to try and delete that, and rather just look at your body and see how you feel. And if you feel great, great. And don't let anything else enter your mind, because you have no control over what that next CT scan shows. So because you have no control over that next CT scan, just let it go and continue to live. So thank you again for this wonderful symposium and the strength of the patient community.